side, you can hear her?
Can you hear me on the other side?
Thank you. All right, take it away.
I can't. Okay, as long as I'm visible there, I'm visible on the other side.
You are visible on the other side as long as you are visible on that screen, yes.
Okay, good. Right, excellent. Well, good evening, everybody, and good evening to the other side. I don't have any disclosures at all, so we'll just move on. I won't talk about any drugs at all today. And usually when physicians attend a meeting and I tell them this, they put down their pens and you can see this sort of glassy thing that happens and they think, well, why are we here? And hopefully by the end of this evening you'll have a little more insight into that. So I'm going to give you a clinical scenario. Mrs. S is a retired registered nurse. Just be very careful when registered nurses get dementia. It's seriously scary. She's always been in charge, and she loved to be busy and organized. Does that ring some bells? Yeah. She was married to a dairy farmer for 60 years, so she's used to getting up at 4 o'clock in the morning. She's never slept for more than 6 hours at a time at night, and now she's in care. She's wandering into other people's rooms at 4 o'clock, getting them up and ready for rounds. She hits out when attempts are made at redirection, and she makes the kinds of retorts such as, "Who do you think is in charge here, young lady?" to the poor care aides. She takes other people's walkers and lines them up in rows. I don't know why demented RNs do that, but they all seem to do that. She becomes very agitated in the late afternoon and bangs on the nursing station door, perseverating, now. And her calling out behavior often occurs at night, waking other residents who find it annoying and distressing. She refuses to bathe, and she hits out during personal care. In other words, she's got everything that we really want to talk about this evening. Now, I want you to think about Mrs. S, because I want you to think a little bit about what you think about her now, and then we're going to come back at the end, and I would be curious to know if your thoughts about her and what your thoughts about addressing her behaviors are now and how those may change during the course of this little talk. So the terminology we are really describing is diverse, depending on the nursing literature, the medical literature, OT literature, and so on. Challenging behaviors, BPSD, neuropsychiatric symptoms, complications of dementia, which we now call major neurocognitive disorder because it makes us sound very posh. Non-cognitive symptoms associated with dementia or responsive behaviors, to name but a few. Oh, incidentally, just to mention, you can all have these slides if you feel so inclined afterwards. And I'm not going to speak to every single thing on the slide, so don't panic if I leave something out. It's just that sometimes people want a little bit more information about some things, and so I've tried to fill those out just from feedback I've had from previous talks I've given. The more common descriptions we get are that Mrs. S is uncooperative. She's predatory because she follows people around. She's disobedient. She's provocative. Her behavior is premeditated, as if somebody with a mocha of 4 can formulate the kinds of thoughts complex enough to do something that is premeditated and predatory. She's obstructive. PRNs are not effective. Please prescribe a more effective, stronger PRN. I often get asked that. And he or she needs to be medicated. And I think all of us have seen this language that is used to describe these folks. And I would just like to ask you one question. If you were working in an orthopedics ward and somebody had fractured their leg, would you write on the chart every day, he can't walk? Okay. So, the definitions of BPSD. The IPA has defined BPSD in 1996 as the signs and symptoms of disturbed perception, thought, content, mood, or behavior that frequently occur in patients with dementia. In other words, to summarize that, These are the non-cognitive consequences of dementia that affect the way people think, feel, and behave. So why do these complications develop, and what do we think about them? And to follow on about our patient with the fractured leg, if a person were to break her leg and has a cardiac arrest as a complication in the OR and lands up in the ICU, what would we think about that person? How would we think about them? Who would be to blame? Would we blame the patient for the fact that they were in the ICU? I mean, after all, did the person ask to break their leg and land up in the ICU? Did Mrs. S ask to get dementia and land up with complicated behaviors? Who would want that? Who would want to get an illness that robs us of so much, that diminishes so much in our lives, and then have the very worst complications of that? So one of the things, and there are a few of my colleagues here tonight, I won't tell you who they are because otherwise I'll tell you stories about me, but one of the things that I harp on a lot about is I always ask, who has the intact brain? Who in this situation is the person with the normal brain? And we presuppose that it's us. And we hope it's us for most of the time. So this is just a classic example of somebody with advanced Alzheimer's disease on the one side, a very atrophied brain, and a nice, plump, normal-looking brain on the other side. And this is something that bears remembering. Teepa Snow, who I'll be talking about throughout the evening, I'm a huge Teepa Snow fan. She's an occupational therapist, for those who don't know, out of the United States. And she's absolutely brilliant. If you've never seen Teepa in action, please Google her and make sure that you've been to the loo beforehand if you're a menopausal woman, because she's very funny. So this is a question that she poses in her seminars and courses and online, is if the person with the intact brain thinks about things, who should make the accommodation in the behavior? So we have somebody who has a failing brain, whose brain is atrophying, but their skull is normal size because bones don't atrophy. So we look at this person and we see them as being the same as we are. And so we have these expectations for their behavior as if their brains were intact. And we ask them to make the most astonishing accommodations. We take them out of their familiar environments. We put them in an institution where they are made to get up at a certain time, like Mrs. S. If she doesn't sleep for 8 hours, she's disrupting the night staff. She loses all her environmental cueing that is familiar to her. And we expect her to adjust and to converse with us and to express her humanity in the way that we do. So what are these behaviors really? And what I'm suggesting this evening is that these are awful complications of a terrible group of diseases. Dementia is a syndrome. Major neurocognitive disorders are a group of disorders. They're not a diagnosis. And they are the main reason, as we know, for admission now to long-term care and tertiary care. Our tertiary unit in Duncan, we have 24 beds. It's an island-wide resource. And everybody who comes to that unit has been significantly behaviorally disturbed in order to get into that unit. It is a consequence of cerebral atrophy with the loss of the structural networks of the brain and the consequent dysregulation of metabolism. Predominantly hypermetabolism, but of course we know that our brains are the supreme multitaskers and that a neurotransmitter in one part of the brain has a different function in a different part of the brain because of the cross-modulation of neurotransmitters and neurotrophic factors and cytokines and so on. So the analogy that I like to use around that is all of us here, and on the dark side in the other room, we have at our disposal a grand piano to express the fullness of our humanity. We have all those keys. We have all those scales. We have all that melodic sound. And as our brains fail, as we develop dementia, the repertoire that we have with which to express our humanity is reduced. until eventually we're left with just a few notes to express the fullness of the human experience, even though it's changed by the process of dementia. That means that one behavior probably has many meanings. If someone calls out, it probably has a number of different meanings. And that means that we have a big job, and that is to try and get behind the behavior to the meaning. So the evidence for these behaviors is that they come, if we look at the cluster analytic models, into 5 groups. The apathy, which is the most common, depression, psychosis, sleep disturbance, and then the agitation and aggression. These are the behaviors that do not respond well, if at all, to medication. Do not respond well, if at all, to medication. And again, you can have a copy of this. I think the bottom line is it's a lot. Right? It's most of those behaviors that we find so challenging. Things like resisting care, sundowning, swearing, unsocial behavior, spitting, pushing wheelchairs around, repetitive activities, and one of the most challenging behaviors to manage, and that is involuntary vocalizations, people who call again and again and again. So how can we decrease the risk for the development of these behaviors? And really, that is the bulk of what I want to speak about, is how can we decrease the risk and how can we address it when these behaviors arise? First of all, we need to look at the environment that the person is in. So we know that best practice now, most of our folks should be in single rooms, but many of them aren't because many residential care facilities are converted hospitals. That the facility should be small and homely. When they built Couch and Lodge 6 years ago, they did these big alterations, and the Feng Shui lady came from Viha, and the Feng Shui lady did all the interior decoration, and she ignored the clinicians, she ignored our OT, she ignored me, she ignored all of us. And we were trying to explain to her what our clients would need, but she ignored it. So she put as a centerpiece in the 2 lounges those crystal fires that are like pretend fires but are psychedelic. It looks like a snoozerlin on LSD, you know. And then just in front of that, there was a space about this wide into which nothing. There was just a space. So I walk up to it and I say, and a few things about the fireplace. And then I said, and this is a post box. And she said, what do you mean? I said, this is a post box. We have to seal this. If we don't seal this, we're going to be fishing everything out of this post box every day. And she was absolutely horrified because apparently it had to do with the dynamic and the balance and the whatever. So the environment is critical. Person-centered approaches are paramount, and I'm going to spend quite a lot of time talking about that. And well-trained, supported staff, and this is where we really need to get the physicians on board, is the time that is well spent is time spent supporting staff and the senior nursing management and OTs and so on. We really need to support our care aides and the people who are working in the front line. And champions, so people who are passionate about this work at every level of care. And then, of course, reversal of risks, such as managing pain, managing depression, managing medical comorbidity. So if we look at the symptom frequency, this is just to give you an impression. The most important thing here is if we look at the neuropsychiatric inventory and other measures, up to 80% of people have some kind of symptom in long-term care. And the consequences we all know. The consequences are massive distress, often moral distress and acute social distress for caregivers, increased health visits, people landing up in hospital for months not being able to be discharged, increased morbidity and mortality. It's very expensive. the terrible isolation and loneliness, and enormous caregiver burnout. We also know that mental health consequences early in the disease, particularly in the pre-dementia stages, place people at risk for the development of dementia. And we're not sure whether those are just vanguards of the process or whether they actually are pro-inflammatory themselves. So the evaluation tools that we use, I want to talk about, and I'm sure many of you use these tools, but the Health Authority has actually spent a lot of time over the last 5 or 6 years developing standardized tools so that we all speak the same language. And that's meant that we have to compromise. For example, the delirium screen which we use in the Health Authority is not my favorite delirium screen, but we all have to say, okay, this is what we're going to use so that we speak a common language. So the first chart that I'm going to talk about is the ABC chart. And whenever a person gets asked to come and see a person in a care facility who has challenging behaviors, in our team, we always ask the folks who are looking after them to use one of these two charts, depending on the clinical situation, so that when we go to see the person, we have some information that can enable us to be helpful. So the ABC chart is a qualitative analysis of what the behavior is within its context and its consequence. So first of all, what was the antecedent? What was happening before the behavior started? Secondly, describe the behavior. Being obnoxious is not describing the behavior. Hitting out and swearing, and I always have to speak to the care aides and the nurses. It doesn't matter, I won't be offended. Write down what they say. It's important not to interpret, but to write this down. So, for example, if we ask nurses to take blood pressure, we don't expect them to write high or very high, okay? We expect them to say 180 over 90, okay? So write down what they were doing. What was happening beforehand? Because often things that we do inadvertently reinforce the behavior. And this is where it's so important to tell the staff this is not about ascribing blame. This is about trying to see what's happening so that we can adjust things. Secondly, to describe the behavior verbatim. And then to describe the consequences of whatever intervention. So a brief thing about the intervention, and then what are the consequences. And when we look at this, we always have the medication, the MAR, next to us. Both the PRN medication and the standard medication, because it's helpful to see whether the administration of a PRN had any benefit, and it's helpful to see whether there's any tracking. For example, if somebody's on Cinemet or some other medication that may be implicated. This is a picture of the DOS tool charting, and this we use even more because it's much easier for nurses. And really all it is you'll see on the one side is the time in half-hourly increments, and then the behaviors are given numbers. And very diligent nurses often exceed 13, 14, or 15. It actually only goes up to 10, but we start having 13 son phoned, 14 daughter-in-law phoned, 15 dog came for a visit, and it gets a bit cluttered. So we try then to pare it down to the key behaviors that we're looking at. And then most of us geriatric psychiatrists and those of us working in the field walk around with these highlighter pens. And then we'll highlight all the ones which are sleeping in bed, and all the threes, which is what everybody wants, which is awake and calm. And it enables us to see blocks of time and to see whether there are patterns. This is an extremely helpful tool, and it's one of Ireland Health's priorities. And so whether it's in an inpatient hospital setting, residential care setting, at our rounds, at our tertiary unit, we have these for any patient who's new and any patient who is unsettled or we're adjusting anything. So the management principles that arise are that, first of all, person-centered approaches are most efficient and meaningful. Secondly, that there should be a team approach. By the time patients come to tertiary care, they and their families have walked such a long and desperate course navigating our health system that if we don't address the family as a priority, we fail. And we all are people within a context, and this is a disease that has a massive effect on families. And if there are small family disagreements, as there are in all our families, and if there's some quirkiness and perhaps a little bit of conflict, those become chasms in the face of this illness. And so it's really important, because often families are distraught and it can be very stressful to look after these families, for us to work in teams where we can support each other. And the emphasis is on improving the quality of the person's life, not defining quality of life as we see it or we would experience it, but in terms of the person in front of us as we get to know them, to build rapport and relationships, and to avoid the side effects of medications as much as possible. So we're really looking at maximizing ability here. And one of the things I want to make clear is that even if medication is indicated, as it often is, non-pharmacological approaches are still a hallmark of what we do. So in our tertiary center, people assume, because it's tertiary care, that we're just really heavy on the meds, and the opposite is true. The vast majority of time we spend is on care planning and working out what's happening for the patients. And one of the challenges for physicians, for those of you who are not physicians, to have some understanding, is that physicians can't bill for this work. And so it makes it very difficult, particularly for family doctors, to spend a lot of time. For those of us in geriatric psychiatry, we have these sessional things we can use. But I won't be buying a waterfront property anytime soon. So this is the evidence of what works so far if we look at the literature. If we look at the literature, patient-centered care, patient health consultations, which are the SORT teams or the community outreach teams, they keep changing their names, but those teams who are specialized in mental health of seniors have been shown to be extremely effective. It becomes very dangerous if these teams are watered down to doing generic, I'll do anything for the person over the age of 65 care, because this is a set of expertise that is rare and we need in the health authority. Meaningful activities and pleasant events, exercise, sensory stimulation, music, Montessori. For those of you who are aware of the Montessori method, there's increasing evidence for the use of Montessori principles, pet therapy, and then there's one study for lemon balm in aromatherapy. I don't know why it's lemon balm, but anyway, and there are some studies suggesting helpfulness in art therapy as well. The problem with these studies is they're all small for actually any of these domains, and the methodology is not particularly strong, but this is the best evidence we have at the moment. So what is common to all these interventions? And this is something that I find fascinating. I try to figure out, looking at the literature and then translating it into a functional application, what is common about all of these? Because some of these are patented, like pieces, for example, and they're expensive. And what is it that is helpful? What are the common threads, if we look at that through that lens? Well, they're all person-centered. So if Mrs. S is used to getting up at 4 o'clock in the morning and having her coffee and her toast with marmalade, because she was born in England, and we're now forcing her to stay in bed until 7 o'clock, where she has to get up and have her coffee and a peanut butter on her toast, Mrs. S is going to be unhappy. And instead of thinking, well, Mrs. S needs to adjust, we have to think, who has the intact brain? And why are we asking Mrs. S to adjust? So that old philosophy of having people in residential care lined up with their hair beautifully coiffed and their teeth brushed by 8 o'clock in the morning, as if they were at some kind of geriatric boot camp, is really something we're trying to move away from, instead of saying, you know, how difficult is it to have a flask of coffee and we can give the early risers some coffee and we can make them some toast. It's much easier than when Mrs. S comes charging down the corridor with a wheel, you know, with a wheelchair that she's using as a weapon of mass destruction. So again, it's about changing that mindset, okay? And the underlying assumption is that all behavior has meaning.
I have a question.
Yep. I thought you were going to wait till I was done.
I know. I'm just encouraging everyone to ask questions because it helps keep the conversation going. I really want to know what person-centered really means.
I'm getting
when I
there.
thought about it, I was like, well, it looks a lot like individualized. So I wanted you to teach me more about person-centered by contrasting that to individualized.
I will do that.
Perfect.
In my next slide, I think, even.
Oh, thank goodness.
Right. So when Dr. Becker ever gets to that time, if we're lucky enough, all of us will get to a time of life where we need support from others. If we're lucky to live longer, I think there will need to be some careful care planning. So what is person-centered care? Person-centered care is more than just individualized care. Person-centered care is the presupposition that people's behavior has meaning, and that staff training and caregiver training in communication, in understanding dementia, in understanding how a person communicates, can enhance this person's care. The primary principle is to view the person as being fully human and deserving of a meaningful life. So individual care would be saying, Mrs. S likes to get up at 4 o'clock in the morning, we'll give her a cup of coffee. Person-centered care means we have found out about Mrs. S. We know the richness of her life. When she gets up at 4 o'clock, and she asks, why aren't we out milking the cows? We say, well, actually, we sent the men out to do that this morning. Aren't we lucky we can just sit and have some coffee? That's the difference. So the starting point of anything we do in our work in geriatric psychiatry is to get to know the person. And getting to know the person means we have to get collateral, as much collateral as we can about who this person is. And one of the most important skills we have is self-reflection, is those of us with the intact brains to think and say, why do we want Mrs. S to sleep on the bed when she wants to sleep on the floor? Why do we want her to do that? And why are we fighting every night when she says, no, this is my bed, and that's the fireplace, pointing to the bed? So whose agenda are we pushing and why? And we come back to this thing, who has the intact brain? We use my story. There are any other kinds of forms of capturing collateral. But you want something that is personalized and doesn't just ask, what they're allergic to and, how many operations they've had. We want to know, who is this person? What are their memories, experiences, fears, and particularly, who were they in their prime? Because that helps us with reminiscence therapy. What were their strengths? Not just what are their challenges. And at Couch and Lodge, we develop what I call our high-value interventions. So we find out from the family members what the person's most favorite food in the universe is, what they just can't resist. And we keep that PRN for when those folks are really unsettled. And then we have a hierarchy of those interventions, whether they be foods, pictures, music, stuffies, whatever they may be. And so that we can address that person's care needs. Because, doesn't matter how bad my day is, if I have a piece of Cadbury's milk chocolate, everything is better. So we all have these things that we use to self-soothe that may not be helpful or healthy for us, but who cares, even if Mrs. S has diabetes? If it's Timmy's, we'll give her Timmy's. She's 88, so she can have her Timmy's. What are their values? What's important to them? So important components of staff and caregiver training, which is part of person-centered care, is psychoeducation and strategies using to distract and so on. And I think we're having a talk on one of them this evening, the gentle persuasive approach. And the studies have shown that for agitation, as an example, using these approaches is as least as effective as using an antipsychotic. So these are the SORT teams, or the health consultants. I'm not sure what they're called in Victoria now. And they make an enormous difference, and they help keep people in their homes. And we need more of them. As we face the demographic changes in the aging population. I'm going to go through these a little quickly, but these are just some, I've amplified them if you're interested, meaningful activities. So I want to spend a little bit of time on reminiscence therapy. The idea is that as our brains fail, our ability to self-soothe is impaired. And some of us may have difficulty self-soothing, even if we have an intact brain. But we know that people who have dementia, if they become anxious, they panic, and they are much slower to return to baseline compared to us. And we know also that if we access positive memories, which are more readily accessible, things that are in the remote past, when people felt in their prime, that induces self-soothing, and that we can then transfer that back to the present. So when Mrs. S is becoming very agitated, what we can do is show her a picture of the farm, ask her questions about the farm, what it was like on the farm. You know, oh, we heard that not only did she deliver cows, but she delivered babies. Did anyone ever name their baby after her, etc., etc. So you see, the more we know about the person, the more we can do. And then that will help soothe her and distract her, and then we bring it back to the present and say, well, let's have a cup of tea and go for a walk. And that limbic sense of being okay and of self-soothing is then translated into the present. Exercise, there's some interesting work being done at UBC around this. We don't have to do CrossFit or run a sub-4-minute mile. All we have to do is to exercise for 30 minutes, actually 3 or 4 times a week as we age. And music, there's a lot of evidence for music. Most of the evidence is around group music 3 times a week, but there is actually even stronger evidence for some one-to-one music. And then for those of you who are interested in Montessori, the reason that it's becoming popular is because it's open-ended. You don't have to complete a task, and it's extremely functional. And it's really about the philosophy of exploring, communicating, and it doesn't require a lot of verbal ability. Sensory stimulation, many of you are probably familiar with, the snoezelen, which comes from the Dutch word which means to explore plus to snooze, and it can be helpful in some situations. Even depression in the elderly, we find the demented people have a lot of difficulty using light boxes. They can be dangerous because they'll look directly at the light box. So a dawn simulator, which you can pick up at London Drugs for $60, is very helpful. And all that does is it simulates dawn. And so in the winter months, it helps people in terms of their circadian rhythm. And sleep, everybody's talking about sleep at the moment. Sleep's important for all of us. But we know that the sleep architecture changes with age, and that's a different lecture. But just to remember that not everybody has to sleep as much as we would like to. So if we go back to Mrs. S, I hope that you're thinking about her in a slightly different way. And I want to talk to 2 examples in this. So the first example, and I love this picture. You know, we're all entitled to a bad day, all of us. So if, and I'm not going to do this to anyone because I don't want to pick on anybody sitting in the front row, but if we, let us say, oh, and I can't because I've got to stay in my box. Okay, so let's say that I had an elderly man sitting in front. That you can imagine. Now you really have to imagine. Imagine that I'm 20 years old, and I'm very attractive, and I've got a low V-neck thing on, like many of the no laughing, you've got to be polite. Many of the young care aides have, right? Those are quite low things, right? And we've got Mr. S sitting there, and I come up and I go, rah, rah, rah. Okay, now this is what Teepa Snow does when she talks about this. And he looks, and I go, you want to, and he goes, and so I then lean over him, and I reach for his belt buckle. Because what I asked him was, do you want to have a shower? But he can't understand that. Now, most of our communication is, of course, and I just have to warn you, I've done some Teepa courses, she comes to you. I spent part of one afternoon like this. She comes right at you. She's merciless. So when I approach him, okay, I nod my head. He will nod his head in reply. Have you ever talked to a child who says, no, Mom, I didn't do it? we do automatically. I think, because I'm thinking that he has the same brain as I have, I think that he's agreed. Okay? Now I lean over him and I grab his belt buckle, because we've got to get that undone to get him in the shower. Now, Mr. S sitting there, if he is profoundly demented, may think one of two things. He may have experienced abuse. He may be very modest. He may be deeply religious. This may be profoundly embarrassing or offensive to him. Or he may think, this is Christmas, okay? And then what will he grab? Okay. So the whole thing that Teepa Snow teaches is we need to keep our agenda behind our backs. If our goal is to get Mr. S into the shower and he doesn't like showering, we're not going to say to him, Mr. S, you're going to have a shower, particularly if he can't understand. We have to take a step back and self-reflect and say, who has the intact brain? And what should I do for Mr. S in order to try and maximize our chances of this working? Again, this is, just to quote Teepa Snow, hide our agenda. We don't have to push our agenda onto our patients. The relationship is more important than them having their hair brushed or their shower at that very minute. And for us to really think about what is really being communicated. One of the most fascinating things Teepa Snow asks is, she says, a really interesting question is to ask, is this person an introvert or an extrovert? And there are many scales you can use, but what it really comes down to is how do they self-soothe? Extroverts self-soothe by going to a party or having contact with others. They're energized by that contact. Introverts self-soothe by retreating, having quiet. And so if a person is an introvert and we put them into a situation where they have to share a room with a very noisy person who talks the hind leg off a donkey, and it's very challenging for them, or we're putting them at a table where they have lunch with people who talk, that's going to be really difficult. Equally, an extrovert might become very depressed and irritable if they're placed at a table with everybody who's mute. So just asking those basic questions about people can be very helpful. So some of the things, what works for Mrs. S? Well, the first principle is what works today may not work tomorrow. And that's just working with folks who have dementia. We have used, these are some of the interventions we've used, giving Mrs. S a clipboard. And then we go on rounds with her. She'll walk around with us and see. Mrs. S is a composite of a number of people. She's not actually one person. But we've done these interventions. And we'll say to her that ward rounds is going to be later, but we're doing admin rounds now. It's amazing how the RNs run away. They say, oh, no, I've done enough of that. And off they go. It's amazing. The other thing we could say to them, it's good news, Mrs. S. Today is Sunday. You're off duty. Recently, we had a couple of RNs in the unit and as patients. And I said to them, we really need to let these youngsters practice. So let's let these youngsters practice, and then you and I will go later and see how they've done. And it worked. It stopped her from being intrusive and going into people's rooms. I've also done surgery. I've delivered babies. I've done an appendectomy on a stuffy cat. I've done a lot of strange things. But the stuffy cat, for example, was that this particular patient, who was an RN, was absolutely adamant that the cat had appendicitis. She was agitated. She was hitting people. And so I was called to give her a PRN. And instead, I took out the cat's appendix. And she was delighted. We put it into a little urinal jar. She kept it at the side of her bed, and it was all sorted. So, again, there's nothing wrong with entering the world of this person. And you probably think I'm crazy. So what I like to say is that this is like the Rosetta Stone. We need to try and decipher the meaning behind the behavior. That emotional self-regulation is very challenging for people with intact brains when stressed. Imagine how challenging it is for those whose brains are failing. Does everybody know what the purple dot is? On my VHAR lanyard, there are 3 purple dots. I'm always being purple dotted. So to be purple dotted in VHAR means you're never unpurple dotted. It's extremely difficult to be unpurple dotted. But I often wonder who should have the purple dot. For example, we have Code White at Couch and Lodge. This is my last story. We had Code White at Couch and Lodge, which is an intervention by clinical staff in violence prevention and then in mitigation during a violent event. And so the folks who had developed Code White had developed it for young adults with mental illness and not for geriatric patients. And we'd had some discussions, and I'd said, you must please use short sentences. You can't use the same approach of reasoning as you would in a younger adult. But, of course, they were the experts in Code White, so they ignored us. The first time there was a Code White, the folks from the adult side, half the building is adult side, half the building is geriatric, came running to show the geriatric staff how to do a Code White. And they had our patient, who was a retired secret policeman, who was about 6'4". They had him like this. This is like stage 3 of the Code White. Things are not going well, right? They had him like this. And there was a guy right in his face saying to him, Mr. Such and Such, I am going to give you 3 choices. Either you can stand up quietly, apologize, you need to learn from this, and go to your room. Or you can sit down in that chair over there. We will stand and keep your hands behind you. He didn't get to the 3rd choice. Okay. So we need to understand that we have to, again, take a step back, even in the face of quite significant aggression, and think, well, that man was terrified. He got purple dotted. But we, as a system, are really the ones who need to be purple dotted. We are not serving these people well. So in conclusion, these phenomena are very common consequences of very common diseases, that non-pharmacological interventions should always be used, even when we use pharmacological interventions, and they should always be the primary intervention. Because even if we want to give somebody significant medication, which all of us in geriatric psychiatry do, there is no excuse for not knowing who this person in the world is and not considering them deserving of the fullest life possible. And so even if they have depression or psychosis, they are deserving of that. That these strategies that I've outlined this evening improve the quality of people's lives, they build rapport, they improve relationships, and they make work a whole lot of fun. And that being person-centered and seeking the meaning behind the behavior is what is central. That all behavior has meaning, that is our presupposition, and an attempt to communicate and interact with the environment, even if it's psychotic in nature. I've just put up there some of the literature that's quite helpful. And the BPSD guidelines for British Columbia is great if you want to look at stuff around medications. If there are questions or comments.
Thank you very much.
I have a question at the back here.
Thanks.
And I saw all the interventions, and I was just wondering where rec therapy fits in there, because it wasn't mentioned.
Right. rec therapy would be, rec therapy would be fantastic if we had it in residential care. Most residential care facilities don't, but meaningful activities is the essence of rec therapy. Mm-hmm. So, yes, rec therapy is absolutely fantastic, and when I've had the good fortune to work with a rec therapist, it transforms everything. We're very lucky on our seniors outreach team. One of our clinicians used to be a rec therapist, and we've learned so much from her because of that. We need more rec therapy and more philosophy of rec therapy, and starting earlier, to address loneliness in seniors populations, starting to prevent people from landing up in residential care. Yeah, it's one of the rarest and most highly valued skills. I don't know how many you have in Victoria, but we don't have one rec therapist in the Cowichan Valley for 100,000 people. Not one.
Wow. Can you push your button to make sure it's not red? Just make sure it's not red. Yeah. Okay, good.
Hi. I work in a few residential care facilities, and a lot of them are shared rooms. So I'm wondering what suggestions you have for working with issues like these in shared rooms, because we have a lot of problems with, you want to pull the curtains, but then bed A can't see out the window, and so then you're preventing them from seeing natural light, or somebody else can't see the hallway. So any suggestions that you have for working with shared accommodations?
Yeah, we have a lot in the Cowichan Valley as well. And I think one of the things is that, unfortunately, the current system we have doesn't allow for creative placement of people. But I think once a person gets into a facility, that's something people should be mindful of. For example, it's really important if they have shared rooms that both people need to understand that the other person is animate. And I'm not saying that lightheartedly, because we have had patients sit on other people because they don't recognize that they're alive, that they're a person, if they're bedbound. So if you have a bedbound person, then it's better to have another bedbound person in that room rather than to have a very active person in that room if that person doesn't recognize that the bedbound person is a person. And it really comes down to the directors of care trying to match as best as possible. And again, the better we know people, the more we can do that. So we have at Cairnsmore, we have 4 people in a room because it's an old hospital, and some of them love it. But I've had folks where the one person just isn't a good fit and becomes completely miserable. And then I think we should feel free to swap people, even though it's disruptive to move. And to see that, we don't put an introvert with 3 extroverts. And that we try and say, okay, if somebody is blind, they won't mind if they don't sit next to the window. And to ask people. Because people who come to residential care may well have quite significant dementia and be incapable of many decisions. But they may well be capable of saying whether it's a problem for them. And thank goodness there's some easygoing people. Even easygoing people get dementia. Yeah.
How about over in the dark side? Do you guys have any questions? Try pushing your mic and ask the questions.
Looks like the Houses of Parliament.
Yeah. I have a question. What advice would you give a physician who's on call and gets the call of she's agitated and she's not going to bed and she's wandering and we've tried a few things and it's not working? How do we make use of what you've taught us today? Because what you've taught us today is big principles for management, and how does that relate to a on-call moment?
So the first thing that I try and do, even if it's 2 o'clock in the morning, is I thank the nurse for calling. And physicians think I'm crazy, but the reason I do that is because I know for a nurse to pick up the phone and phone a physician, it has to be bad. At 3 o'clock in the morning, it has to be bad. And that they've probably delayed it until it's right at the edge. So that's the first thing I do, because that changes the tone of the whole conversation. It says to whoever's phoning, I'm going to listen to you and I'm going to take what you say seriously. And I find that if I do that, not only is it just the decent thing to do, but we then make a joint decision rather than the person feeling that I'm not hearing them and I'm not taking into account everybody's safety and so on. The next thing I do is ask questions around safety. Now, and the nurses who work with me know that I ask a lot of questions, and it doesn't mean that I don't trust the information they're giving me. It means that I'm trying to understand it. And so if I don't know the nurse, I'll say that. I say, I'm going to ask a lot of questions just so I can understand it. And I say, is everybody safe? Where are you? Where is the patient? What is the patient doing now? So I ask some basic questions to establish that this isn't a crisis, that somebody is storming at somebody with an IV stand in hospital, or this, because then we're looking at crisis pharmacological intervention. Okay. And that's a completely, that's, I think, a talk for later. That's different. If it's an acute situation of safety, we have to act to keep the staff and the person safe. So we have to establish that. So if we establish that it is not imminent danger for the staff, then I'll say, okay, tell me what you've tried. Tell me, usually I know the person when they phone, because they usually phone me from a unit that I'm familiar with. And I'll say, well, what led up to this and what's happening now? And usually the person is either pacing up and down, or they've gone to sit somewhere where they're not supposed to be, and things like that. And then I will say to them, okay, have you got, and I always ask, what are the PRN medications available for this person? What has worked in the past? And make sure they've got those. Make sure there isn't any sign, that this person's acutely delirious. And then I make a suggestion based on what the current situation is. I might say, well, does he need to go back to his room right now? If trying to get him back to his room is resulting him going into other rooms because he's agitated and flustered and he doesn't know which room is, what about if you don't try and get him back to his room? What about if someone just sits down and has a cup of tea with him? Is that possible, given the other demands on your life, what else is happening, and so on? If it's possible, then I say, well, leave him. If there is a spare room, which there never is in residential care, or if there's a chair that he wants to sleep in, let him sleep in the chair. So try not to force that situation if you can possibly do it. Just let it diffuse. And that is the first thing, unless it's a safety thing. And then if it's a safety thing, well then, depending on how acute that is, we will have to use a pharmacological intervention to keep people safe. And I have to find out how familiar the staff are with handling that situation.
Good. Last chance for questions. Other side. Good. Thank you so much.